June 3rd marked the beginning of Community Health Improvement Week. Sponsored by the Association for Community Health Improvement, an AHA affiliate, this nationally observed week-long event recognizes community health professionals for their passion and dedication to improving the health of the communities they serve. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly, senior writer at AHA and your podcast host. In this podcast, Nancy Myers, Vice President of Leadership and System Innovation for the AHA Center for Health Innovation, speaks with Duane Reynolds, President and CEO of AHA's Institute for Diversity and Health Equity. Their conversation is about the meaning of health equity and how it factors into the health and well-being of a community.
Duane, welcome to the podcast.
Thanks, Nancy. I'm really happy to be here with you today. Appreciate the opportunity to talk about a topic that I'm extremely passionate about.
So why don't you start by telling us a little bit about the Institute for Diversity and Health Equity here and what the work is of that organization in AHA?
Sure. We are actually celebrating our 25th year anniversary this year. So it's a really exciting time for the organization. We have had sort of an evolution in our focus, but we started out with really the intent of improving diversity in healthcare management. Over the last couple of years, with transformation in healthcare, we have connected diversity as a component to how we achieve health equity. And so our goal is really to help hospitals and health systems in the field really be empowered in how they address and deal with diversity, inclusion, and health equity.
I'd like to dig a little bit deeper into that and have you talk a little bit about when you think of the term diversity, what do you mean by that? And how are diversity and health equity related to each other? How do they intersect with each other?
Sure, that's a great question, and one that I think a lot of organizations, particularly as they're starting out on a journey in diversity, will oftentimes think of race and gender. And so diversity absolutely is that, but diversity is so much more things. I define it as what makes us unique as individuals. What are the characteristics that we are either born with or we learn over time that really define who we are? Of course, the items that we're born with, so our gender, our race, our ethnicity, those are things that innately we can't change. But then there are components that, for instance, we acquire over time. Educational status, our professional work that we do, our religious affiliations, our political affiliations, all those things really come together to make diversity. And what I also then like to focus on and have organizations think about is, once you have diversity, how do you really capitalize on diversity? And that's really about inclusion. So inclusion is the ability to create a space that people feel that they belong and that they can bring their whole selves to work. And so diversity and inclusion is really how we begin to shift the conversation about organizations and how they create this space, not only for their employees, but in healthcare, thinking about how we then translate that to our patients, our consumers, our community. And that's where the health equity link really comes into play. So having an organization that is culturally competent really allows us to then feed into what our healthcare operation is and how we serve our patients and consumers.
So when you think about health equity and how being able to see the world through different lenses, which is what diversity and inclusion brings to the table, are we focused on redesigning our care delivery system in different ways to take into account individual uniqueness of our patients? Or are we looking at community factors, or is it a combination of both?
Yeah, I think it's all of the above if we're doing it correctly. So, for instance, there are some hospitals and health systems across the country that have created centers of excellence for Latino healthcare or LGBTQ communities, because what we know is that there are nuances, cultural nuances to each of those diverse communities that actually can be embedded in our care process and our teams, how we train our staff to address the cultural needs of those communities, some of the barriers and challenges that those communities have, some of the disease prevalence and incidence that is different than the majority community. And so we can, in fact, make changes inside of the walls of our healthcare models, if you will. But then we should also be thinking about how we move upstream and understand the impact of social determinants of health, for instance, on certain communities. If food insecurity is an issue that you have as a patient, then your ability to make decisions about whether or not you have food or whether or not you have money to buy that prescription is an important one that will ultimately impact your overall outcome. And so we have to begin to think about those upstream factors that also impact total health. And so it's a combination of both the internal things that we're doing and changing and transforming care models and how we begin to partner and look at our community and what we can do more upstream to actually impact their equity and total health.
So that seems like it can be overwhelming.
Yes.
If you think of it in the big picture and all at once. How are you seeing hospitals and health systems do this work successfully, and how do they start?
The start is really understanding that we as individuals are different when you think about the employee side of the picture. Understanding that we all bring our unique characteristics to the table. So how do we begin to break down any silos or barriers that may come as a result of that? But then when you think about it from the business perspective, I think what I've seen nationally is that organizations, one, make a commitment that health equity is a part of our strategic agenda. And so you get all of the stakeholders aligned around the fact that health equity should really be woven in all that you do throughout the healthcare system, because ultimately it's impacting the patients in the community that you're there to serve. It has to be broken down in components, and you won't solve it overnight. It's just like any other strategy that you have within the organization. You start with your strategic goals, and then you've got to break it down to tactical components that are really phased over a period of time. So my recommendation for organizations that are just starting out is to first collect race, ethnicity, and language data. That is sort of the foundational basis for how you begin to understand disparities. If you're thinking about it from the cultural side of your population, take your employee engagement data, which most organizations do some sort of survey, take that data and slice it by demographic categories to understand if there are actually opportunities to improve the experience, the engagement of various demographic diversity within your employee population. So it first starts with that vision, but then you just have to break it down to tactical things that allow you to build the foundation to be able to do the broader things. So moving from internal to external and sort of thinking big picture long term.
And as hospitals and health systems are rethinking their care delivery for all of their patients within their communities, they are beginning to, and many of them are farther along on this journey than others, really move outside of the walls or the virtual walls of traditional healthcare delivery to move a little bit more upstream, or at least to appreciate the social factors that are affecting the lives of their patients or their potential patients. How important are partnerships in that world? Because I think that hospitals often feel a heavy weight that they have to figure this all out on their own. But what are the community partnerships that they should be thinking about in terms of helping them understand better what the different needs are of the different populations of patients that they're serving, or the different needs of the communities that they exist within and are committed to serving?
Well, I think you're absolutely right in terms of us needing to come outside of the four walls of our hospital organizations. And I also think the inverse side, public health professionals and the institutions that are built there have to also think about how to marry what they do with hospitals. The reality is we exist as people in a society, and we don't just stop and leave certain parts of ourselves outside of the walls of the hospital when we walk in. We bring all of our baggage, whatever it is, and that baggage in some cases means that you've got to address social determinants of health, which typically hospitals, that's not the core business that we've seen for most hospitals, unless you're a Kaiser and you're an integrated system and you've been focused on population health for quite some time. But the majority of hospitals are still operating in a fee-for-service environment. They don't necessarily see their role as reaching outside and don't feel that they have the resources to really be able to do that. But the reality is there are small scale tactical things that you can do outside of your four walls that begin to build relationships with the community. For instance, there's quite a few organizations now that have partnered with barbershops in local African American communities to do blood pressure checks for the men that come into those barbershops. And that has led to discovering that a person has high blood pressure and doing the clinical interventions that actually help prevent any further progression and their need to come into the healthcare, acute care, and or outpatient setting. And so I don't think that hospitals can do it alone. I think it is going to require more partnerships that traditionally we haven't been really focused on as a part of our overall strategy. I think internally, hospitals tend to have community health departments. It has been a limited scope that may not tie directly back to the clinical care operations. And I think even within the organization, those walls have to come down to be able to understand the interconnections there. And then you start to partner externally for the things that you may not do as a core business. For instance, providing transportation, providing food service. So I think that partnership is the only way that will really solve this. And it's going to take some moving out of our comfort zone. But ultimately, it will benefit our patients and communities, and particularly as we move to a value-based care environment, we have to be concerned about that population health perspective and managing the care of a population, which means not just when they're inside of your organization, but quite frankly, before they even hit your door.
So that brings me to a point that I talk a great deal with about folks when I'm out and talking with our members in the field. And that's understanding that while our hospitals and health systems and all of the great folks that work within them are doing their work because it's the right thing to do and because they want to care for their patients and for their communities. At the same time, healthcare is a business. And in order to be able to continue to do all the good work that we do, we have to be able to break even at the end of the day. And I think folks are really struggling with the business case model and how that's evolving and how that needs to include more than just the clinical care delivery equation that we've used historically in the past, to get to that magical margin number. So talk a little bit around how you see health equity as being a core component of a business model and making the business case for including that equity lens in our work.
That's a really good question, and one that I have quite honestly spent my career trying to figure out. I started my career on the provider side. Spent 14 years running faculty practice administration clinics in academic medical centers. So I understand that perspective of you have to be able to deliver care efficiently, effectively, but also have profit that you can reinvest in your organization if you're a nonprofit entity. And so the way that I view this, and I admit I may have a bit of a biased view, but the way that I view this is when we think about a person who has been admitted to the hospital. Maybe they've come in through the emergency department, they've been admitted, they have a length of stay. Hopefully that is managed well, but some cases not. There's a real cost to all of that. And understanding that health equity is a driver of total health. If we are able to intervene in certain circumstances, so let's say that person has been discharged, it behooves the hospital to be thinking about how I prevent them from readmitting or coming back into my emergency department. I mean, there are real incentives and payments tied to that. So if one of those factors of readmissions is they were discharged and they have no place to go, they're homeless. Well, traditionally, that hasn't been the hospital's business, but now we have to start to think about that, because if they readmit, it means something to us financially, and we don't want to see the patient readmitted. And so we have to be concerned and think about health equity in terms of the business, because it actually does drive whether or not people end up back in the emergency room or end up back in the inpatient side, based off of nuances that we maybe hadn't thought about as being our responsibility in the hospital. So it could be a language barrier and their lack of understanding of the directions upon discharge that ultimately landed them back into the hospital. It could be an access issue simply because they don't have the transportation to get back, or they can't take time off of work to get back to our organization in order to have a primary care visit that ultimately prevents them from readmitting to the hospital. And so all of those things to me tie back to why it's important from a business perspective to have a lens of health equity and to have a lens that understands social determinants of health and how they will impact the bottom line. And so, again, in a fee-for-service environment, sometimes it's hard to think about the investment that you've got to make upstream in order to realize a downstream investment. But as we continue the march towards value-based care, and we will continue, we have to really consider health equity as a component of our business and our financial sustainability.
So, Duane, tell us a little bit about how you see the work of the Institute at AHA progressing over the next couple of years to support hospitals and health systems in this work.
Well, I certainly have spent the last few months really trying to crystallize that. I've been in my role about 4 months now. We have so much opportunity, and I feel like our time is now to really make change in the field in this area. And so the AHA and the Institute for Diversity and Health Equity, we need to play a more prominent role in really helping our members understand the progression of diversity, inclusion, and health equity in their organization, because it is a big challenge. It's not something that you solve overnight with the snap of a finger. It really is about thinking about the fundamental purpose of our organizations to serve our patients, our communities, our consumers. That fundamental purpose is not just about the majority group or the group that receives healthcare and don't typically face the same challenges that more vulnerable communities may face. Health equity is about understanding that there are unique needs and circumstances that each patient and person will face. And by virtue of that, we have to adjust to meet the needs of that particular person, patient, because that ultimately will lead to their total health, the outcomes that we're seeking for each person. So it takes a more prescriptive and thoughtful, nuanced approach to each person or population that presents to our organizations. And so when I think about this, I live and breathe it. It is my passion, it is my purpose, and I just think, what amount of inequity is acceptable? And I think most people would say none. And so that has to be our guiding light for what we do and how we make change in the industry. And the Institute for Diversity and Health Equity is here to help. I encourage anyone that is interested in learning more to visit our website, which is diversityconnection.org, or reach out to our offices. We're very happy to help wherever we can. And we also want to hear what your challenges are so that our strategy that we are evolving really reflects and meets your needs.
Thanks so much for your time today, Duane, and for sharing your thoughts and the direction that you're heading in your new position. It's been insightful for me, and I'm sure our listeners have found this to be extremely helpful in driving their work forward as well. For more podcasts and tools, resources, and education to help you in the field advance community and population health, including the work that's being led by our Institute for Diversity and Health Equity, please visit aha.org. And thank you very much for your time today.
Well, Nancy, thanks for having me today. I really appreciate it.